Good afternoon, everyone. Today I am presenting a case of a 20-year-old male presented in a OPD with a chief complaint of sudden diminution of vision in the right eye for 1 day. Diminution of vision was marked, painless in nature, and patient experienced mild blurring of vision in the right eye since last 10 days, but the patient ignored the symptoms. There was a positive history of hematuria, 4 episodes in the last 6 months. There was no significant personal history. For hematuria, patient was treated with tablet norfloxacin plus tinidazole combination 2 months back. Ocular examination was done. Position of head, eyebrows, lacrimal apparatus were within normal limit. Uncorrected visual acuity of right eye was 1/60 less than N36, and left eye it was 6/6 and N6. Anterior segment examination was within normal limit except right eye. Grade 1 RAPD was, grade 3 RAPD was present. Fundus examination was done with indirect ophthalmoscopy. Left eye was within normal limit. Right eye, disc was hyperemic with splinter hemorrhage was present. Dilated tortuous and engorged retinal veins were present, and a whitish appearing retina was present along the distribution of cilioretinal artery suggestive of cilioretinal artery occlusion. So, as it was a case of vascular occlusion in a young patient, investigations were done accordingly. Baseline investigation were normal. Serum homocysteine and coagulation profile were within normal limit. As the patient was giving a history of hematuria and there was hyperemic disc and few cells were also present in the vitreous, inflammatory pathology etiology was suspected, so connective tissue disorder profile was done, and investigation came out negative except C-ANCA that came out positive. Patient was referred to the immunologist, and there the patient was advised X-ray paranasal sinuses because the patient was giving a history of recurrent sinusitis and headache. Complete opification of axillary sinus on the right side and partial opification with bony destruction on the left side was noted. On the basis of this, diagnosis of cilioretinal artery occlusion secondary to vaginous granulomatosis was made. Patient was treated accordingly with IV methylprednisolone 1 gram for 3 days, tablet prednisolone 1 mg per kg per day with slow taper, and tablet cyclophosphamide 1 mg per kg per day. After 4 weeks of treatment, this was the result. Uncorrected visual acuity improved from 1/60 to 6/24. So, vaginous granulomatosis is a distant systemic clinico-pathological entity characterized by granulomatous vasculitis of upper and lower respiratory tract with frequent involvement of kidney. Ocular involvement occurs in 50% of patients. Ocular involvement with scleritis, episcleritis more common than vascular occlusion, vasculitis and retinitis as evident by various landmark studies done on ocular manifestation of vaginous granulomatosis in which retinal artery or vein occlusion, vasculitis and retinitis is a rare presentation. So, the take-home message in this, when a young patient is presenting with vascular occlusion, we should always rule out, connective tissue disorder and inflammatory pathology once the baseline investigation is normal. Thank you.
Okay, I'll just mention one small tip. Wegener's granulomatosis is now called granulomatosis with polyangiitis, because Friedrich Wegener, who basically discovered the disease, had some Nazi connections here. So you should always mention the newer names.
Very good. And basically the take-home message is any young person with vascular occlusion, apart from the regular diabetes, hypertension, we have to look for the entire immunological profile, SLE, sarcoid, vaginous, and even COVID nowadays, and HIV. HIV is very important. So there should be a protocol where you will test for every patient. These particular tests will be done.
Post-vaccination also we saw some
Yes,
patients
yes.
after COVID vaccination.
One thing is also very important, it can be isolated cilioretinal artery occlusion, or it has to be associated with AION, especially in Wegener's disease. Yeah. So you have to, your picture was also indicating towards that only, your fundus picture. This was quite edematous and it was hyperemic.
Yes. Yes.